Diabetic foot is a chronic condition affecting almost half the patients affected by diabetes mellitus throughout the world. Its increasing prevalence is mainly due to the increasing prevalence of the underlying pathology, but also to the increasing prevalence of the patients who successfully heal from the acute phase of the condition and which develops a chronic, recurrent diabetic foot. The severity of the pathology is mainly related to the epipathogenesis of the condition, which is related both to the vascular complications at the lower limb and the neurological impairments, which affect both the sensitivity and the motor components of the lower limb, exposing the foot to the increasing probability to undergo to accidental trauma, which transform a chronic risky condition in an acute phase characterized mostly by ulceration or fracture and dislocation of the target organ, which is the foot. Since the epipathogenesis is multifactorial, also the treatment should be multidisciplinary and integrated in a way that all these different aspects of the epipathogenesis of the condition should be addressed, both the vascular one and the neurological one. And one of these critical issues of the strategy to manage the diabetic foot is related to the ability of successfully contrast the trauma and the repetition of the trauma in a patient which usually is not confined in bed but is ambulatory and continue to perform an active life. The offloading of the foot is a crucial aspect of the therapy of this condition, and is particularly difficult to tailor this therapy to each single case. When one thinks that different clinical presentation and different clinical aspects of this pathology could be interested by the offloading. So you may have to offload chronic ulceration. You have to think that this would imply the application of an offloading for 20-30 days, but you also may have to deal with the chronic recurrent Charcot foot, in which the offloading should be applied up to 2 years continuously. So it's something that it's very scattered and related to the peculiar presentation of the pathology in this peculiar patient. The golden standard of offloading in most aspects of the diabetic foot has been since to now the total contact cast, which is a fiberglass cast, not removable, applied by experienced technician in a dedicated setting, and it has been proved to be effective in relief pressure and to be effective also because it overwhelms the compliance of the patient. Once you apply this non-removable total contact cast, the patient keep it in place without any possible manipulation, and its continuous application of the offloading ensure its efficacy. Since, as we said, the condition is very different in the different patients, the possibility of modulating the offloading in this patient has become evident in recent times, and shifting the attention and the emphasis from the method of offloading to the strategy of offloading has been a consideration that make the philosophy of offloading make a step forward. This is especially true when one considers then to apply a total contact cast, it takes having an expert technician, a dedicated setting, the materials, all a facility to do that, all things that in many diabetological centers and in many diabetic foot clinics is not available. It's been found that less than 12% of the patients that would have been treated with a total contact cast did not actually have it because of the lacking of these factors in the place where they've been followed and managed. So, having the possibility of go beyond this method and having alternative has been important. It's important, in my opinion, to make an effective offloading to be true for many more patients than what is now when one considers only total contact cast. The possibility of having different kind of strategies to offload the diabetic foot is important for many reasons, and technology helped us in recent time developing new products, new devices that have been proved and applied in this patient with success. Our experience we made recently with a new novel product whose name is Optima Diab convinced us of the utility and the effectiveness of this product, which has technical features that make it suitable for many different clinical conditions of the diabetic foot, from the post-operative condition in the infected foot to the ischemic foot with plantar ulceration, to the neuropathic foot, also to certain kind and certain aspect of the chronic Charcot foot. We used it intensively in the last 3 years, and following a published paper which we wrote following a clinical trial, double-blind randomized trial, with this device compared to total contact cast, which demonstrated its superimposability to the golden standard. We were able to limit the use of total contact cast to only the acute phase of Charcot foot and widening the use of Optima Diab to almost all the other conditions of diabetic foot which deserve an offloading. The reason why we were so enthusiastic of these products are both related to its economicity, which we found being very interesting, since a treatment with Optima Diab costs less than 7 times the cost with the total contact cast for, say, the neuropathic ulcer, but also for its versatility, since its use can be adapted and shaped to the tailored to the wide variability of the presentation of diabetic foot. So, using Optima Diab in the diabetic patient could be indicated, for instance, after, as we said, an operation in which the patient should be controlled more frequently than for a chronic ulceration, but also in the infected foot, in which closing the foot in a rigid total contact cast could be dangerous, to the ischemic foot, in which the local ischemia is a contraindication to the use of contact cast. Another aspect that makes us prone to use this device is the fact that it can be rendered irremovable, so transforming what is originally a removable device in a non-removable device, in what we call in the paper we wrote an off-the-shelf equivalent of a total contact cast. This has been found also by other users, and our results have been doubled and repeated by many other centers, and we are now running a multi-center repetition of the trial we did, comparing the non-removable form of the Optima DIAB device to the removable Optima DIAB device and the total contact cast, trying to verify if beyond the removability, the non-removability, the device in itself has technical characteristics that makes it superimposable at least, but maybe also better than the total contact cast. If the results of this multi-center trial should be positive, and I have not elements to affirm the contrary, this new device could be proposed as a new golden standard for the management of the diabetic foot.